on this computer. Okay, so when you start, so I will critically appraise Swaminathan's paper which he sent me. Okay, is that okay, Swaminathan? Again,
okay,
it's
sir.
all academic.
No
okay?
problem, sir. Okay,
nothing
sir.
personal. It's academic.
No, sir.
So
no, sir,
Swaminathan sent me his paper actually uploaded on the group, and what I see here is 10 points. I won't talk whether they are valid or not. I will talk about it when we discuss. But you got to remember that you have 60 minutes to read the paper through, and the appraisal starts from the title. Okay, always it starts from the title. Is the title well written or not well written? Does the title represent what the paper is trying to say? You have to talk about authorship. Is the authorship properly represented or not? You have to talk, sorry, just one second. Something on the camera. Is it me with the hair sticking out, or is it the camera? Okay.
All right. We are seeing correct.
I don't have any hair, but that one hair which sticks out upsets me. Okay.
We are not seeing it, sir.
You are not seeing it, but I'm seeing it. No, that is the story of life. Okay. So you have to talk about authorship. Is it adequately represented? The first author is actually the guy who has done the study or not? Is that telling you that story or not? You have to talk about institutions. If you find that somebody who does aortic surgery, okay, writes about lung cancer, that's not a good article. If you know what I mean, this is how you have to. So if he calls it Department of Minimally Invasive Cardiac Surgery and then writes about thoracolaporotomy, then that's not a good article. It's a discrepancy between the authorship and the institution. The next thing is then you have to talk about the abstract. You must, I think every one of you must go to the European Journal website, either the ESTS or EACS website. Go to the European Journal of Cardiothoracic Surgery. Because you're giving a European exam, you have to follow the European guidelines. So I want every one of you to go to the European Journal of Cardiothoracic Surgery and download the document on author information.
Okay, sir.
Okay, in that European Journal website, when you go, you will get author information. I want you to download that author information. I want you to read through what is needed to write a paper. That author information tells you. So the abstract has to be 300 words or 250 words. If it's not a correct, properly written abstract, you have to criticize that as well. So the next point is the abstract. You've got to talk about the abstract. You've got to talk about, did the abstract adequately describe what they wanted to describe? Will this abstract be picked up, be shortlisted for an oral presentation in a meeting or not? Or is it a poorly written abstract? Then you go each one down by down, and it should go aims or objectives. Then you have to talk about methodology. You have to criticize the methodology in detail or appraise the methodology. It doesn't matter. Then you've got to talk about the results. Are the results adequately represented or not adequately represented? And then all the points which you're going to tell me now when we discuss this paper as to, you know, what was the inclusion criteria, what was the exclusion criteria, is the demographics accurate, does it represent your patient population or not, stuff like that. And then you go into the statistics. Very important to look at statistics. You have to talk about whether the statistics were properly done or not. And this, because we are doing this for the first time, I'm going through in a bit more detail. Is that okay? Next time you will talk more and I will listen. But today I just want to explain to you what I need to see when you are sending me a paper. So the one that you send me is a very, very, very basic analysis, is my impression of this. And you will not be able to talk 30 minutes on this. Would you be able to talk 30 minutes on these points?
No, sir. Yes, sir. No, sir. No, sir. I should be doing, as you said, doing it more detailed, sir. Yes, sir.
Much more detail, much more detail. What is the feedback from everybody else who has written their analysis? Just give quick feedbacks. Whether you have done this or you have not done it. It's okay to have not done it because you didn't know what to do. What did you do, Amol? Have you written it down?
Yes, sir. Sir, it's a compared to Swaminathan's, it is little bit more, but I think as far as 30 minutes are concerned, it is still very less, sir.
Okay, so you got to think about what will you reproduce for 30 minutes. Okay,
Yes, sir.
because the Viva is designed for whatever 20-30 minutes, but you must have more stuff to
Yes,
talk.
sir.
And if it's
And
less, that's okay.
yes, sir. And at the end of the analysis, I thought that I just pointed out the negative things about the article, but I should have concentrated on the positive aspects also,
Very important.
which might be useful for us to follow it in our practice, which I
Okay.
forgot to.
So one feedback on that is that whenever you talk about an article, do not talk in a negative way. Okay, you know,
Yes.
in life we can say that he is ugly, or you can use the word saying he is not beautiful. Do you understand that? The word
Yes, sir.
beautiful is a better word to hear than the word ugly in a conversation. In the exam, you do not want to use any negative words.
Yes,
Okay.
sir.
Always use words which are positive connotation, but say that he's falling short on beauty.
Yes, sir.
I would have liked him to be more this, more that, but what is there is good enough. Do you understand what I'm trying to say? So
Yes,
never
sir.
in an exam use negative words. The moment you start using negative words, it creates a negative feeling in the examiner. And that's not good. And you don't know whether that author is from the Examiners Institute or not. The
Yes.
worst thing to happen if you criticize his left, right, and center, and then you find out that actually it was his registrar who wrote that paper. That would be a complete disaster. Okay, so always use positive words with a mellowed down version. So never use the word ugly. Always use he could have been better looking, or you know what I mean, or his personality would have been enhanced if he had put on a green shirt. You know, it's a different way of saying the same thing. So always remember in your analysis. What about you, Vinita? What was your experience of this analysis? Give me 1 second. I'm just going to open my window. 1 second.
Okay.
Just 1 second, okay? Sanobar, can you just shut off the heating? It's really hot in my room. Sorry about that. The room's become very hot. Yeah, sorry, Vinita.
Sir, I have tried to analyze by the SWOT analysis which you told that day.
Yeah.
But whatever I have written is just to speak for hardly 5 to 10 minutes.
Okay.
The points which Somanathan covered, I have also written, but 1 or 2 points extra. But otherwise, it's almost similar. But I think it needs a little more detailed analysis.
Okay.
And
so now you've understood that actually you have to start from the title of the paper. Okay. Yes. So always start from the title and keep going down. Okay, that's the way to do it. Vikas, what did you do?
Sir, I did not appraise the title and the abstract. I went straight away to the main text, and I only tried to find out negative things. I did not try to find positive.
So 1 minute, Vikas. When you are browsing through a journal, okay, what catches your eye?
Yeah, this thing is that is the first thing. When I got the topic, it says that SABR is better than surgery. So it was very first thing is startling. SABR better than surgery. And so first impression was this guy is bluffing. And that is why I try to look the negative. Yes, sir.
That is why the title is the most important in any paper. If you want your paper to be published, a title has to catch your eye. You understand that? So the reverse is, if you want to write a paper, get the title right. Okay. Like I wrote a paper on Ayurveda and robotic surgery. Okay. And the title was 200 BC to 2015 AD. Mm-hmm. Do you understand? Now 200 BC to 2015 AD could be anything, but it is catching. It's eye-catching. And the subtitle of that paper was an analysis of Ayurveda versus robotics, Ayurveda in robotics. But the title 200 BC to 2015 AD caught everybody's attention, and it got cited many times. Okay, so title is very important. Fine. So Vikas, remember next time, start from the top and work your way down. Okay, Swaminathan, I spoke to you. Anish Gupta, are you with us?
Good evening, sir.
Hi, good evening, Anish. We haven't met before, have we?
No, sir. I saw you first time in 2012 when you came for MAMC surgery update.
All right, fine, fantastic. So tell me about your analysis. Again,
Sir,
this is a
my
feedback
analysis,
first. Yeah.
sir, again, same thing, sir. My analysis was very much similar to Dr. Swaminathan's, and I didn't point out any positive things in the article.
Okay, now let me get back to you. How many actually read Swaminathan's analysis and then did their analysis? Be honest with me. This is the forum where you can be honest. How many of you read Swaminathan's analysis and then read the paper and then did your own analysis? Admit it if you've done it. It's not a problem. Yes or no?
So,
I did not.
I started reading his analysis, but I thought I will compare my analysis with his. So first I went ahead with appraisal, and I compared the points.
Now, did you read it before you read the article or after you read the article?
Sir, before I read the article, I opened his file.
You read it. So now let me give you a feedback on that point, okay? If ever a patient comes to you with a lung cancer, okay, and he puts a report in front of you which says that this is a tumor, the report says this, okay, not you, the report says this is a tumor invading the chest wall with invasion of the pulmonary artery with loss of fat planes between the pericardium and the tumor. Okay, this is on the report. When you see that CT scan, what are you going to see?
We are going to see the same thing.
Exactly the same words that he has written. Exactly. Whatever he has written in the report is what you will see in the CT scan. I promise you this. This is life.
Yes, sir.
What you will miss out is the metastases, the 1 millimeter or 2 millimeter metastases on the left side, which what you did not realize is that report was written by a radiology registrar who is sitting in an AC office who has never seen the patient. Whereas you have a patient in front of you and the patient just told you that I also had backache. And when the patient told you he had backache between the shoulder blades, you will quickly look at the spine to see if he's got metastases in the CT scan or not. So by reading Swaminathan's report, and Swaminathan is at this level just a registrar. He is not a consultant, registrar in critical appraisal, okay? Swaminathan, don't get me wrong.
No problem, sir.
In the subject of critical appraisal, Swaminathan is just a registrar. And he has written his report on the basis of his experience. Unfortunately, by reading his report, you've completely shattered your critical appraisal. Because the moment he's written something, I'll just read out something. He wrote stratification criteria, pathology requirement, and you looked for stratification criteria and pathology requirement. I promise you, you will not look for anything else. So next time you want to do an appraisal, do not. That's why I don't like to have you share this on the group, because
I apologize,
other people.
sir. Sorry,
no, Swaminathan, don't get me wrong. I'm happy you send it because I actually wanted to read it. So others didn't send because they realized maybe I don't want it. But I'm happy you send it. See, always when we make mistakes, we learn from it. So everybody has learned in the group today that never, ever, ever read a report before you see the angiogram. Never, ever, ever read a report before you see the CT scan. So by reading Swaminathan's report, Amol, unfortunately, your appraisal got tossed. Yes, and because he wrote 10 points, you wrote 13 points, and that's lost.
Yes.
You understand what I'm getting at?
Yes, sir.
So that's a mistake that you've made. It's a learning point that I'm trying to make to you. Okay. Who else is with us on this group? I can't see. Who's that? Vijay. Vijay, are you?
Yes, sir. Yes, sir. Good evening, sir.
Hi, good evening.
Yes,
have I met you, Vijay?
No, sir. Not yet, sir. Good evening, sir.
Tell me, Vijay. Tell me, did you do the appraisal?
I did do the appraisal, sir. I did Swaminathan's report and then I did the appraisal.
So you read Swaminathan's thing and
yes,
did the
yes,
appraisal.
Sir.
Okay.
Yes, sir.
How much different is your appraisal from Swaminathan's appraisal?
It was less than Swaminathan, sir. I've got only 8 points, sir.
Yeah, but is it quite similar to Swaminathan's
Very
appraisal?
similar, sir. Very similar, sir.
So that's why. So this is what happens when you read somebody else's report. You will just copy paste his report onto here, because the brain is a very strange creature. A brain is a creature which thinks in pictures. It doesn't think in words. Does not think in words. It thinks in pictures. And the moment you read Swaminathan's report, that picture is formed in your brain. So when you go through the actual paper, you will not find anything else except Swami. You will in fact even look for these words. You will start looking for the word stratification. Okay. You will start looking for stars or Roselle trial. This is what you will focus on, rather than trying to understand your own self, that actually what is this paper about. Okay?
Yes.
All right. Simran, are you with us? Can you talk or can you not talk?
Yes, I can talk, sir.
Okay,
Correction
give me
going a
your
little
feedback
bad, sir.
on the paper.
So I didn't analyze it so extensively, sir. Like Swaminathan, I also analyzed it only, actually only the statistics. And
Okay.
again, it's all negative points. It's not.
So would you be able to
it's not-
talk for 30 minutes on your
Oh
analysis?
no, sir. No, nowhere near. Not even 5-10 minutes, sir. So
Okay.
there's just points picked up.
So now, has everybody got a copy of that paper in front of you? That's what I want to know.
Yes, sir.
Okay, let me just bring it up. I'm trying to find the paper. Where is it? Okay, all right. So today, because we are doing this for the first time, we will put the paper in front of us. Okay, so you guys put the paper. Should I share my desktop? Okay, let me share my desktop. All right.
Yes.
So you can see the paper with me, and then I'll take you through what we are thinking. Not end meeting, but share screen. I want to share my screen. This is the screen I want to share. And can you see this?
Yes, sir.
Yes, sir.
Everybody can see it. Let me just increase the size of it. And let me take this away. We do not need to see ourselves. Okay. So now, Swaminathan, because you took the lead,
Yes, sir.
you start this, okay? So
Yes, sir.
now I want you to start, forget what you wrote, okay? I'm not interested in what you wrote. Look at the paper in front of you and start criticizing it or appraising it. Not criticizing, but appraising it. So start with this appraisal and we'll go through it one by one, okay? So
sir.
tell me what you see in front of you. I've got the screen in front of you. What can you see?
Sir, I can see the title now, sir. Stereotactic ablative radiotherapy versus lobectomy for operable stage 1 non-small cell lung cancer. A pooled analysis of 2 randomized trials. This is the title, sir.
So Swaminathan, in spite of me telling you clearly that you have to start at the top of the paper, you have lost the vision because I didn't point out that what is on the top here. What is this?
Okay, sir. Lancet Oncology,
what is this?
author manuscript.
Okay, so where does the appraisal start?
Sorry, in the name of the journal, Lancet Oncology.
Tell me, is this a good journal or is it a bad journal?
Yes, sir. It's a good journal, sir. Good journal.
Very good journal. Okay, it's a very, if you look at its impact factor, it is very high. Okay, so that's the first, that's how you start an appraisal. Okay, not just from the title. In fact, you start from the journal. Where the hell is this published? Okay, so my first statement in this appraisal would be that this journal, this paper has been published in a high impact oncology journal. Okay, it's not just Lancet, but it's Lancet Oncology. So it is a very dedicated journal for cancer surgery. Yeah? So that's the first appraisal that you have to make. You agree or no?
Yes, sir. Yes, sir.
Okay. What's the second point you see here?
Sir, I can see the date and year of this thing, sir.
You want to say anything about that?
So yeah, I can say that it's not very the current very current things. It's quite recent one, but I want to make the comment, sir. It's a recent.
5 years is a long time, man. In
Okay, sir.
Cancer surgery, 5 years is a long time.
Okay, sir.
Yeah.
Okay, sir.
If this was 2019 or 2020, that would be great.
Okay,
but
sir.
5 years is a very old paper. Technology has changed.
Okay,
Immunotherapy has come into the domain. the various management of cancer has changed a lot in 5 years. So do you
Okay,
think
sir.
is it a paper on which you will base your clinical practice?
No, no, sir. No, sir.
Yeah, probably I would like to read it in detail before I can base my. I'm not saying all old papers are bad, but
Okay,
if
sir.
you do want to change practice, it has to be current paper. You understand?
Okay, sir.
So
Okay, sir.
2015 is an old paper, I think. I personally
Okay, sir.
believe it's an old paper. Okay.
Okay, sir.
All right. So that's good. And then the DOI is given, which is very important and which is good. I like this. That tells
Okay, sir.
you that you can actually reference the paper. Okay,
Okay,
a
sir.
lot of people in their CVs will write that I wrote a paper on management of hydrated cyst, but they don't give you the DOI. And in a CV, if you don't give me DOI, I can never check whether you have actually written this paper or not. See this part. Can you see what I've highlighted?
Yes, sir.
So that is also important. Okay. The other
Okay,
thing
sir.
that you have to look for in this information is whether is this an abstract that has been published, or was it presented in a meeting and not published, so it is just an abstract from the meeting, or is it actually a first author paper? Okay, so you have
Okay,
to
sir.
look at all those things in this. So this is
Okay,
so
sir.
far so good. I like that. Let's go ahead. What do you think about the title?
Sir, so they're saying they're comparing two modalities of treatment, sir. One is surgical versus non-surgical radiotherapy, sir. They're comparing, sir. A pooled analysis of two randomized trials. They are just analyzing it, sir. So it is a paper based on
What do you
two
think
other
about the
randomized.
title? No. What do you
Sir?
think of the title? What do you think of the title? Is it well written, or is it poorly written?
Sir, it's a well written title, sir. According to
Why?
because they're clearly saying what they want to say in the paper by the title itself, sir. I can, by seeing the title itself, I can understand that this paper talks about radiotherapy versus lung cancer, was lung cancer even for operable stage 1 non-small cell lung cancer, sir.
Is this a
So
controversial title, or is it an okay title?
it's a controversial title, sir. It's a controversial.
Why?
Sir.
What are the 2 points which are controversial in this title?
Sir, for stage 1 non-small cell lung cancer, the established treatment is surgery, sir. Like
Excellent.
the gold standard is a surgery, sir.
Excellent. So this is actually a very, very good title, because they are talking about SBRT. They want to put you out of business. They want to put the surgeons out of business, because they're talking about SBRT in stage 1. Stage 1
Yes,
lung cancer. For God's sake, a stage 1 lung cancer will never go to a radiotherapist. You agree or no?
Yes, sir. Yes, sir.
You agree or no? Stage 1 lung cancer should never reach a radiotherapist table. What the hell are they doing by randomizing a patient to radiotherapy? Do you understand that? How the hell did you manage to randomize a patient to radiotherapy versus lobectomy? Which essentially means that 50% of their patients got a non-gold standard treatment for the sake of science.
Yes, sir.
You understand that?
Yes, sir. Yes, sir.
So this is a very, very controversial paper straight away. I'm not saying it is right or wrong. Don't get me wrong. But the moment you read the paper, you say, how the hell, which ethics committee allowed them to, and again, the key word is operable. You see, operable. They'll use the word operable. For God's sake, how did 50% of operable stage 1 non-small cell lung cancers ended up getting lobectomy? Because randomization means 50% here, 50% there. You agree or no?
Yes, sir.
So this is the first critical analysis will come from the title. I am very, very, very upset about the word operable in this paper. Okay. And the second word which upsets me is stage 1. So this you have to convey to the examiner. You have to convey that when I read this paper, sir, I was aghast. Because how did they manage to get ethical approval for sending operable stage 1 cancer, 50% of patients got SBRT. Yeah? You agree with that or not?
Yes, sir. Yes, sir.
Yes, sir.
Okay. So again, this is another, it's a very dodgy word. A pooled analysis always tells you that the sample size was not adequate. Okay, the moment you need to pool data means you have not got adequate sample size in one or the other arm, or in one trial or the other trial. Why do you do meta-analysis? Can somebody tell me, why do you do meta-analysis?
To increase the sample size. One of the
Absolutely, one of the
advantages is
main indications of a meta-analysis is to increase the sample size. Rarer the disease, more the chances of a meta-analysis, because one single study cannot get the same. It's like doing aortic dissection. You know, you see 10 a year as compared to 1500 CABGs. You understand that? So whenever papers come in with a small randomized control study of a dissection, then usually the guidelines come when they have done a meta-analysis of multiple small RCTs, purely to increase the sample size. The moment somebody is using pooled analysis, the word pooled, it is quickly suggesting to you that they did not have adequate sample size, either in one or the other arm. Guys, is it making sense what I'm saying to you, or is it getting to be very stressful or boring?
No, sir.
it is making absolute sense.
It's making sense to you. Okay, so start with the title always. Very, very, very important, okay? The title gives you the story straight away. So start with the journal, start with the date of the paper, start with the DOI. Also find out whether it is an original article or is it a meta-analysis or things like that. That usually gets published somewhere here, okay? Sometimes some papers are given to you in the exam which are PUIB. So they are in publication, under publication. Okay. So you must tell to the examiner that this paper has not yet been published in the journal. It is under publication. Okay.
Yes, sir.
Then look at this. So already I have given you about 2 minutes worth of things to talk about.
Yes, sir.
Yeah. Even before I went down to everything, I've given you 2 minutes. Okay, now do another analysis for me. Look at this, okay? Look at this. Up to here, do me an analysis. What do you read into this? What are the words you will give me back when you read this?
There are very few surgeons, and all of them are radiologists.
No. Before that, that is sub-analysis. But first, the moment you read this, what is the first story that you get out of here?
So it has been done in various parts of the world, sir. Various centers.
What is the research word for that?
Multicentric.
Yeah, this is a multi-center, and also what else? What is this? This is Netherlands. What is this? Houston, Texas, USA.
Different.
So
the different populations are being considered
across the continent.
No. What is across the research? Yeah, what is the word? What is the research word you have to use?
Heterogeneous population.
No. What is the research word? Simple. The first statement you will make in this is a multi-center, multinational study.
Multinational.
Yes, sir.
Yeah. So straight away you have to analyze this. This is a multi-center, multinational study. Okay, that is the first word I would do out of this. So before I look into who is the authors and all, it's a multi-center, multinational study. Okay, that is very, very important. You've just told the the examiners that I have actually understood that this is a very. So what is the strength of a multi-center study, and what is the weakness of a multi-center, multinational study? I send you this point in my notes. I will ask you back, what is the advantage if they've done a multi-center, and what is the disadvantage of a multi-center, multinational?
Advantage is that it proves proves the applicability to different cohort of population.
Okay, so
And
number one is
disadvantage is the
different cohort of, no, more advantages. Tell me all advantages. So one is different cohort of population. Good. What else? What other advantages can you think of a multi-center study?
the sample size will be large.
Yeah, you can get a larger sample size. Okay, that is the key thing. You must always talk in statistical terms. When you are critically appraising a paper, the language should be familiar, okay, to what I'm used to listening to. So it's a multi-center, multinational study suggesting that they must have had a good sample size. Okay, the shortcomings of a multi-center, multinational study is?
Bias will be more.
What do you mean by bias? What? Tell me in simple words. I agree with you. The bias is possible.
Standardization of protocols will be different.
Excellent. That is the most important thing. That when you do a multi-center, multinational study, the standardization of protocols have to be very rigid.
Yes, sir.
If any of the center does not follow a rigid standardized protocol, the study will go for a toss. So everybody, so the protocol, the study protocol, the concert diagram of this study has to be rigid. It cannot be flexible. The moment it is flexible, then the data is not consanguineous. It is not comparable. So there must be a database created for this with very rigid columns and very rigid entry points. You understand that? Okay.
Yes, sir.
Yes, sir.
All right. Now, tell me, what else do you want to say about this? What about the mix?
Sir, the problem is I cannot apply to my local, I cannot extrapolate the results to my local practice, sir.
Okay,
Because-
just one second, Swaminathan, just one second.
Sorry, my earphones have gone dead. So just speak. Somebody speak.
Hello?
Yes.
Yeah, hi. Okay, that's fine. So now I'm back on my computer sound. So tell me, that is a later extrapolation. First, about the paper. What do you think about the mix of this group?
The patients have been operated by different surgeons
Okay.
of different experience.
Oh, yeah. So what I want you to look at is this. Okay, I'll point out 1. Okay. 2. Yeah. 3. 4. 5. Okay, I pointed out 5. Did you see it on the screen?
Yes, sir.
Yes, sir.
Yes, sir.
What do you think about the mix of this group? Good or bad?
There are
Just tell me. It doesn't matter what it is.
It's good to have people from all the concerned
It's a very
departments
good mix.
to
I think it's a very good mix. I think it's a very good mix. What is the strength of this paper in terms of the mix? Which of the departments gives real strength to this paper?
biostatistics.
Yeah. So this is not a random paper written by random guys. This is a good paper written by a very good mix of people, including biostatistics. So they must have had very good standardization protocols. You agree or no? This is the strength of this paper, that there is a biostatistician involved in this paper. You understand that?
Yes,
They
sir.
have also got radiation oncology involved. They've also got radiation physics involved. What I don't see, in one place, I see also a pulmonologist involved. Yeah, can you see that? There is a pulmonologist involved. But what I don't see at all is a medical oncologist. The medical oncologists have had no input into these patients. So the question that arises is, were these patients discussed in a multidisciplinary team meeting or not?
Yes, sir.
You understand? So this is how you analyze that. Did these guys actually get an oncologist in the MDT or not? In the tumor board, were there? Because I know that the paper is related to SBRT and to surgery. So they've got that. But when you're treating cancer, and when you're treating cancer in a large gamut of patients, then the medical oncologist is very much part of the group. And I don't see even a single medical oncologist being mentioned in this paper. Okay. The other important thing that I do see in this mix of patients is, I just saw it. Where is it? 1 second. Okay. Just where is it? Where is the, trying to just quickly get to that. Radiation oncology. I saw, just 1 second. I can't seem to find it again. Department of Cardiothoracic Surgery. Where is it? I just saw it. Biostatistics.
Biometrics.
No, not biometrics. Biometrics is also important. But 1 minute. Pulmonary medicine, radiation oncology, biometrics is good. So this is good. This is a point worth mentioning. This is the word I was looking for. Okay. This is the word, cyber knife. I saw the word cyber knife being used in this group. So that's good. This is a group of radiation oncologists who are familiar with the new technology of cyber knife. You agree or no?
Yes, sir.
Yeah. So biometrics is also important. I like that. I like that they have got a biometrics guy on board, and they've got cyber knife as well. Somewhere they've mentioned cyber knife. So that's good. So this is a good mix. Now, one of the things that I cannot make out is how many surgeons, how many oncologists. That's a very detailed analysis. But basically, the feeling is that this is more of a radiation oncology, because all of these are radiation oncologists. Okay, most of them seem to be radiation oncologists and very few surgeons involved. So that's the other answer which I would have put, that it feels as if there are more radiation oncologists in this paper and very few surgeons involved in this paper. Okay, I think Vikas said that, and that's a very valid point. Okay, all right. So now let's go further down. Okay, so now you got to look here. Forget the paper still. You're not yet finished the paper. What do you see here? What do you see here?
The corresponding author is the Department of Radiation Oncology.
He is a radiation oncologist. Yeah. So if the corresponding author is a radiation oncologist, what is his interest?
SBRT.
To show that SBRT is better.
He is trying to push SBRT. Okay. So that's important. That's a point I would make, that the first author of this paper is actually a radiation oncologist. And I strongly suspect that the author was written, that the paper was written with an idea of trying to promote SBRT in stage 1A lung cancer. Yeah. Again, see, you look here, JYC, SS, EFS, and JAR designed the study, collected, analyzed, and interpreted the data, and wrote the article. So if you look at JYC, SS, MAR, and whatever else, they are all radiation oncologists. You agree or no?
Yes, sir.
All four authors, if we go back and look at it, JAR, who is JAR? Jack A. Roth. So all of them are radiation oncologists. You agree?
Yes, sir.
All other authors have just contributed data. Okay, they've just contributed data. Now, the other thing which they have not written in this, what I would like to see is what are the keywords. So the keywords is missing from this paper. You agree?
Yes, sir.
Any paper that you publish, you're supposed to write keywords at the bottom. And so keywords are there. Another important thing is this. So this, I would say very early, that all authors have declared no competing interest. Do you think this statement is correct?
No.
So what would you say in this? Very gently and very carefully, what would you say in this?
There is likely to be a bias towards their own specialty.
Absolutely.
To report a positive results in favor of SBRT.
Though they have made the declaration of interest that they have no competing interest, that could be financial interest, but four of them who have designed the study are radiation oncologists. And if four people who have designed the study are radiation oncologists, there is highly likely that the whole bias was towards radiation oncology. And they were trying to push SBRT over surgery in the management of stage 1 in lung cancer. Yeah? Are you understanding what I'm saying? Okay. So now go to the, let's go to the, let me just go back to the, let's go to the abstract. Okay. So somebody take it up. Somebody else take it up. Okay. Who wants to take it up? And this will work only if you volunteer. Otherwise, it will not work. So you have to, come forward and volunteer to talk. So who wants to take it up? Again, you are all mature people, so I don't want to point fingers at anybody. Next.
Okay. So I will take it, sir.
Who is that? Vikas. Sorry, Vikas, I can't see anybody, so you'll have to tell me who it is.
Yes, sir.
Vikas.
Vikas, yes, sir.
Okay, Vikas. What do you think about the abstract? Open it on your laptop as well. Also.
Abstract they have in the back. Yes, sir. Yes, sir. In the background itself, they have said that standard of care for stage 1 lung cancer is surgery. And a SPRT has increasing role in inoperable cancers. So here they are reporting 2 independent RCTs, and they are themselves clinically both were closed early due to slow actual. So
Come
here they are going to analyze that.
1 minute, Vikas, come back. Okay.
Yes, sir.
They said that the standard of care for operable stage 1 lung cancer is lobectomy. Okay. But
Lobectomy.
don't forget this.
Yes, sir.
Don't forget this.
With
This
lymph nodes. Yes, sir. With medicinal.
Mediastinal lymph node dissection or sampling. That is
sampling.
the key thing in this. Can you do mediastinal lymph node dissection and sampling when you're treating with SBRT?
No.
You agree?
Yes, sir.
When you stage a patient as a stage 1 lung cancer after surgery, okay, after surgery, that means you're actually telling the MGT or the tumor board that this patient has a less than 3 centimeter tumor in the right upper lobe, and more importantly, histologically, there is no tumor in level 2, level 4, level 7, level 9, and level 8. You agree or no?
Yes,
Yes,
sir.
sir.
So that is the real definition of a stage 1 lung cancer. How the hell can a radiotherapist who has treated his patient with an SBRT tell you what was the status in level 2, level 4, level 7, level 8, and level 9 lymph nodes? Can he tell you that?
No.
So there is the fallacy of the whole paper. Okay? Start off. First line is tells you that this is not a correct story. Okay? All right. Okay, now carry on. Again, SBRT, the other important word here is this one.
SBR has role only in inoperable cancers.
Yeah, SBRT is in inoperable cancers. Okay. Now, what makes a cancer inoperable?
When it is close to some vital structures and when we cannot resect.
No. What makes
If the patient is having
the patient is comorbidity are very high.
No,
It becomes
he's unfit for surgery. Yeah, he's unfit for surgery.
Yes, sir. Unfit for surgery. Yes, sir.
Person is unfit for surgery and he has coronary disease, and you give him SBRT, and he died 1 month later with an MI. Is that correct? Does that say that SBRT is bad for patients because it causes death of patients?
No.
No. You understand that? So the cohort of the two groups cannot be same. The cohort of an operable stage 1 cancer versus a cohort of an inoperable stage 1 cancer cannot be same. The consort diagram of the two groups, the demographics of the two groups cannot be same because the risk factors are completely different. Either the patient had severe triple vessel disease, or he had very, very bad lung function test, or his PFT was FEV1 of 1. So how can you compare two groups when the demographics are not the same? Do you understand what I'm saying?
Yes, sir. Yes, sir.
Is it making sense what I'm saying?
Yes,
Okay,
sir.
good. So now the other words, keep reading, keep talking.
So,
Again, I'm going in more detail in this paper just to give you an idea of how we criticize, okay? So don't worry about the time we take today. It's just the
yes, sir.
first time we're doing it with you guys, so you're not experienced. But if you keep doing a few more, you will quickly pick up these points as I'm speaking, okay? So first time it'll take more time to critically appraise. So is that all right with everybody?
Yes, sir.
Okay, good. So keep going, but two independent.
So, but two neighbor randomized phase 3 trials of SABR in patient with operable stage 1 NSLC, stars and Rosal closed early due to slow accrual. We
Very,
aim to assess overall. So,
very,
very big point.
very
Big
quickly,
point, sir.
very quickly, what is the problem with this?
Yeah. So again, how did they get an operable patient to go with no surgery?
Is it ethically accepted? If you
It
have
is
a
not acceptable.
is it ethically acceptable to actually put an operable stage 1 cancer into a stars and this thing? I mean, if this happened in the UK, they would be shot. They would lose their registration. And then they are saying was closed due to slow accrual. Why do you think accrual was slow?
People will not consent.
Absolutely.
Yes, sir.
How the hell can somebody consent for a non-gold standard treatment when there is a gold standard treatment which tells you that the survival is 94% in stage 1A lung cancer? How can a patient actually consent to have a procedure which has no description of survival? Because at the end of the day, cancer is all about survival and recurrence, not about what method they did. You know, the technology doesn't matter. The patient wants to live. He wants to get rid of the cancer. So the accrual, this is the key thing. Why the hell was there a slow accrual? Because people will not want to be randomized. So what they did to overcome this slow accrual is to pool the data. Can you see that? They have very quickly pulled the data. So this is absolutely, these two lines tell you the whole thing. So what are you going to do to this paper? If you are a surgeon, what are you going to do to this paper?
Just don't follow it. Just throw it to the bin.
No, yeah, what I would do is I would read it out of interest to know how ridiculous people can be. And then I would quickly throw it in the bin and tell them to, F off. That's what I would do to this paper. But now my question comes to you, okay? In the analysis, you must say this. Why do you think Lancet Oncology published this paper?
Just to raise the citation.
Yeah, which means what? What does that mean?
More controversial papers, more controversial the paper, more likely it is to be cited, and it increases the impact factor.
No, what do you mean by citation? What will happen to this paper? If you were a surgeon and you're writing a paper on stage 1A lung cancer, surgery is the gold standard for stage 1A lung cancer, what will you do to this paper?
I will always criticize that this paper did it wrong.
But in the process of criticizing the paper, you are citing the paper in your references. And because you're citing the paper in your references, the impact factor of the journal goes up. Because what is the formula for impact factor?
Number of citable, all the citations
each article
in past 2 years, and total number of citations in past 2 years.
So it is the denominator which is more important, right? It is the denominator. More the citations, more is the impact factor. It goes up. And that is why a shit study like this, which is completely controversial, gets published in a journal like Lancet Oncology. Did you understand the concepts behind it? Okay. All right, carry on. Tell me about the methods.
So this is one of the biggest fallacy that they are going to.
Aims of the study. Are you happy with the way they have written the aims? Have they actually written the aims of the study?
No, they have not mentioned the aims.
They have not used the
They've
word
just
aims
given
at all.
the background.
In the background, they have sneaked in that we aim to assess the overall survival. They just slipped it in because they did not have a clear objective. Did they have a clear null's hypothesis?
Null hypothesis is not mentioned anywhere in the articles.
Not mentioned in this bloody study. How do you set an objective of a study? By clearly defining the null hypothesis. And the null hypothesis should have been, what should have been the null hypothesis for this study?
There is no difference between surgery and stereotactic radiotherapy in treatment of stage 1 non-small cell lung cancer.
That's a very positive null hypothesis. Do you want to go more negative? Go on.
Null hypothesis should have been that surgery.
Yeah, go on.
That SBRT is not better than.
Difference. You use the word no difference. I would not use the word no difference in the null hypothesis. What would I say? Come on, tell me. Vikas, you were just saying something.
Not inferior.
SBRT is not better than surgery for operable
Not even better. Even worse. What else would you say?
Poorer than this thing. No.
Even worse. What would you say?
Surgery is not inferior to radiotherapy.
Even worse. What would you say?
Hazardous.
SBRT has no role in the management of operable lung cancer. Did you understand what I just said?
Yes, sir.
That is the null hypothesis. So moment you start with that null hypothesis, no role, not inferior, not this thing. SBRT has no role in the management of operable stage 1A lung cancer. Okay, that's the null hypothesis. And then what you do is you use the methodology to disprove this statement. So moment you disprove the statement, the way you disprove it is you say not that it is superior. You can say it is equivalent to surgery. You know, the results or the prognosis of patients with stage 1A lung cancer, operable lung cancer, is equivalent to surgery. However, surgery carries more morbidity. Hence, SBRT is a good treatment for stage 1A lung cancer. Did you understand how the analysis is done? Guys, are you understanding? Please give me feedback. I can't see you.
Yes, sir.
Yes.
Yes, sir. Yes, sir.
Yes, sir. Yes, sir.
So that is what you have to do. As a scientist, if I wanted to analyze this thing, I would say my null hypothesis is SBRT has no role in the management of lung cancer, operable stage 1A lung cancer. Use all the words. Operable stage 1A lung cancer. And my aim of this study is to prove the null hypothesis wrong and to state that SBRT is equivalent to surgery in prognosis for stage 1A lung cancer. However, the morbidity of SBRT is lower than surgery. Hence, it should be considered a treatment modality in stage 1A lung cancer. If I was a radiation oncologist and I was trying to push a paper, this is the statement I would have made. Yeah? So there is a lot of falsities in this paper. And I deliberately brought this paper for you guys to understand how papers are manipulated. This is complete manipulation of data. And it took us 3 or 4 lines. Okay, 4 lines. At least it took me 4 lines to understand what they are trying to do. The problem is 98% of the readers, including all 6 of you, may not understand what they are doing. And you will end up in the exam telling me that SBRT is the best thing for operable lung cancer. You understand that? So be very, very careful of papers. People are always biased. They always write rubbish things, and they will try to push forward their point. Okay? All right. What is the other problem here with this? In this line, in this background?
They are trying to study, report results from a study which were not completed. Both of the trials were stopped, and they are going to analyze those trials. So that means there was something wrong when they were conducting the trials.
Okay,
that is the reason it was stopped.
Yeah, I completely agree with you. But let me go one step back. Let me go to an even simpler question. What is the problem with up to this point? Did you understand all the words on this up to here from background to this point to here trials? Did you understand all the words? Read it again. And did you actually understand all the words? Is there any word in this which you do not understand?
Slow accrual.
Sorry?
Accrual, sir.
Accrual. Okay, accrual is actually that is a matter of language. So accrual means slow collection. Accrual means collecting something. So that's okay. But more importantly, never mind the English, but is there something in this 5 lines that you don't know? You do not understand as a reader?
Sir, short forms are being used.
Yeah, which one?
Stars and Roselle.
Yeah, what the hell is stars?
Yes, sir.
What the hell is Roselle? You know, what the hell is this? How can somebody write an article in the Lancet and, you know, they have started with NSCLC and they have explained to you what the word NSCLC is.
Yes, sir.
They have explained to you what is NSCLC. I don't mind that. They have written the word stereotactic ablative radiotherapy, and I don't mind that they have told you what a SABR stands for. That is okay with me, because now they have repeated NSCLC. I know what it is. They have repeated this. I know what it is. What the hell is this? Can you write a paper or an abstract where you cannot explain what is the word abbreviation that you're using or acronym that you're using? Yeah? Why do you think they did? Why do you think they used the word stars and Roselle here without explaining to you?
They did not want the reader to know what the trials actually were.
No. Even simpler than that. Even simpler. What do you think is the reason why they put stars and Roselle? Why did they not tell you what was the whole form of stars and Roselle? What was the full form of stars and Roselle?
They want to show that these 2 trials are so big trials that.
No?
They don't want us to go back and check for them. They don't want us to cross-refer to those things.
No, actually, I will cross-refer. The moment I see stars and Roselle, I will quickly Google, because I don't know what is. Why do you think they use the word stars and Roselles without explaining what is the full form of stars or Roselle? See, you write about Mars trial for mesothelioma, and you always, when you write the paper, you say mesothelioma and radical surgery. That is Mars. Okay, MARS is mesothelioma and radical surgery. So when I write a paper, if you read the Mars paper, you will write in the first paragraph, they will write Mars, mesothelioma and radical surgery into bracket MARS. And then the rest of the paper will use MARS. Why do you think they use stars and Roselle without explaining what it is?
Sir, stars includes only radiotherapy. Sir. Surgery is not included.
No, even more simpler. Even more simpler. Even more simpler explanation. I'll tell you what the explanation is. Even more simpler.
Sir, there might be discrepancy between these two, the full forms of these two studies.
They're not twisted. They are honest people. Why do you think they use the word stars and Roselle without giving you the full form of stars and Roselle? Word count. Okay. because the moment they must have had 250 word count, okay, something like that, and they must be going to 270. And whenever you try to cut down the word counts, what you try to do is take away unnecessary words. That's how we do normally, isn't it? When we send an abstract to a meeting, we have 250 word count. We always end up writing 300. And then we start cutting down things. And so I believe that they did not bother to explain stars and Rosal because they were running short of words. Because this would be 5 extra words. Can you see that?
Yes, sir.
5 extra words, and this is 5 extra words. And so that probably if the word count was 250, they must have gone to 260. And so how to reduce 260 to 250 is to just put the abbreviation without explaining what the hell is that abbreviation. But that is poor writing. That is very poor writing. Okay? You cannot expect a reader to know what is stars and Rosal. You cannot. Okay? Okay, let's go to the next. Did it make sense? Again, I'm emphasizing some points because I want you to understand how authors think and how they write papers. Yeah? Okay, let's go to methods now. Somebody come to methods. Again, it doesn't matter if you don't do the whole paper. Even if you just finish the abstract, I'm happy. But at least you'll understand how things go. Okay? So let's go to methods. Somebody else take it. Hello? Somebody else take the method. Yeah, who is? I'll just give your name. I can't see you.
Amol, sir.
Amol, take Amol.
Yes, sir. Sir, in methods, they start like eligible patients in the stars and Rosal studies were those with clinical T1 2A, that is less than 4 centimeter, N0 M0, operable non-small cell lung carcinoma. Patients were randomly assigned in a 1:1 ratio to stereotactic radiotherapy or lobectomy with mediastinal lymph node dissection or sampling. We did a pooled analysis in the intention to treat population using overall survival as the primary endpoint. Both trials were registered with clinicaltrials.gov. They have given the numbers, referral numbers for clinical trials.
Now critically appraise this methodology. Though I know it is still an abstract, but critically appraise this methodology.
Sir, first of all, they have clearly stated that they have taken only stage 1 NSCLC, but they have not mentioned what are eligible patients. Means they have just mentioned it as eligible patients, but who are eligible patients, we don't know, sir.
So some of the eligible criteria are not. So inclusion criteria are not complete in this.
Yes, sir.
What else?
And
method.
Patients were randomly assigned in a 1:1 ratio.
1 minute. When you do inclusion criteria, what is the next step? When you speak about exclusion.
Yes, sir.
So, there is no mention of exclusion criteria at all. I mean, was there no exclusion criteria? Or is it because this is an abstract, so they just reduced it to talk about only inclusion criteria? But it's a very poorly written thing where, there's no clear mention about inclusion or exclusion criteria. I'm sure in the paper they must have mentioned it. This is only an abstract. But the biggest question which comes to me, which is not mentioned here at this point, is ethics approval.
Yes, sir.
I cannot see a mention of ethics approval, and I hope to God that when I go down and read the paper, I will find about ethics approval. So that's very, very problematic. Okay. What else? What else you read here? What else do you read here?
Patients were randomly assigned in a 1:1 ratio to SABR and lobectomy with mediastinal lymph node dissection or sampling, sir.
So here, what do you think is the problem with that?
Sir, the number of patients may be different in both the trials, sir, but how they can do it 1:1?
Absolutely, absolutely. I don't understand this 1:1 business at all. And also what I don't understand is what was the randomization method?
Yes, sir. They have just mentioned the randomization, but
How
what
they-
kind of randomization they have not mentioned, sir.
what else is missing in this line? What else should have been there? So forget the analysis part, but in the methodology, what else should have been there? When you write
Sample.
sample,
Sir, time frame.
sample size calculation,
Yes, sir.
time frame, good. What else? What else is missing in so far? So far, it might be there in the rest of the paper.
Statistical method used.
Sorry,
Statistical method used.
statistics is not mentioned at all. They haven't told us how they analyzed it. Okay, so that's there.
Yes.
What else is missing?
And only primary endpoints are mentioned, sir. Only one primary endpoint.
Endpoints were not mentioned. Morbidity was not mentioned. Yeah,
Yes, sir.
there's only one endpoint, which is survival. Okay,
Yes, sir.
overall survival. What they have not mentioned is it 1 year survival? Is it 1 month survival? Is it 5 year survival? You know, this
Yes.
is exactly how the cardiologist pulled wool over your eyes as cardiac surgeons. This is exactly how they did that. You know why? Because they published literature where they showed that we deployed the stent, and immediately after deploying the stent, the flow was good. However, they did not, in a lot of cardiology literature, they did not mention what happened 1 month, 1 year, 10 years, and 15 years later. A lot of literature misses that point. And so they make a conclusion that stenting is better than CABG in coronary surgery. Because on table, you got a good flow after my stent went. But they don't do a repeat angiogram at 6 weeks or at 1 year or at 15 years. You know, they say, oh, the patient's myocardial viability is good, or the echocardiographic findings of the patient was good. But if you look at coronary surgery literature, almost all literature talks about angiographic findings in the long term. Do you agree with this or no? You are cardiac surgeons, a lot of you. You know, when they talk about radial artery, total arterial revascularization, a lot of big studies mention
Yes,
angiographic findings at 15 years. That is why Lima to LAD is the best graph, because angiographically you can show that the Lima is patent. Lima to LAD is patent. Whereas a lot of cardiology studies suddenly move their endpoints to echo findings or, DSE findings. And this is a complete bullshit that people do. So overall survival, what the hell you mean by overall survival in lung cancer? Does it matter to the patient whether he's alive at 1 month, or does it matter to the patient whether he's alive at 5 years or 10 years? What matters?
long-term survival.
So they've not written overall survival at 10 years.
Yes.
Not seen the word overall survival. Kaplan-Meier is what? Kaplan-Meier curve is a survival at 5 years.
Yes, sir.
So they have not written overall survival at 10 years was the primary endpoint. So would you accept this study at this stage?
No, sir. We will have a lot of questions on this study.
We have a lot of questions, okay? Good. Now, one good thing that I see is this. Okay, so what is the importance of this?
Sir, it means that they have registered their trial into a US-based clinicaltrials.gov. So they are genuine studies and not fake.
So they are genuine studies and they went through ethics committees.
Yes, sir.
You have to get a LREC before you can do this. What is LREC?
Local Regional Ethics Committee.
Huh?
Local Regional Ethics Committee.
Good. LREC. So I'm now teaching you the words to use when you're talking critical appraisal. Language is different. So far, we have not spoken surgery language. We have spoken a completely different language. And that is why you have to practice with somebody like me, because in India, unfortunately, the MCH teaching program does not teach you the language of research methodology. So far, did all of you feel that I'm using a different language?
Yes, sir.
Yeah?
Yes, sir.
Have you used that language in your analysis on the paper?
No, sir.
No, sir.
Yeah, so that is the difference. Okay, so that is why our Indian students, when we go into international exams, we get a little backtracking, because not because we don't know our stuff, or not because we are not good surgeons, but because we don't know what language to speak. We're not talking about English here, but we're talking about the language of the examiner, what he's used to hearing. So if you were describing this to me and you start talking about, if you don't use the word multinational, multi-center trial, and you talk about this is many countries and many hospitals involved, then that language is a different language. I will not identify with you. It tells me that you don't know how to read a paper. Okay, and that is how we assess people when they're reading papers, when they're doing a critical appraisal, that are they using the correct methodology and the correct language to describe a paper. Okay, all right, let's go on. Let's go to the findings. Are you guys okay so far? Anybody wants to take a break?
No, sir.
Is this a beating you are getting?
Sir, we didn't get the words. Sir. What did you say?
Is this a beating that you are getting? Are you getting a beating at this moment?
No, sir.
No, sir.
We are learning, sir.
Yeah, but I actually are getting a beating because you don't know. Okay, go on. So again, my job today is to point out the holes, okay? Point out the gaps. All right? All I'm trying to do is get you into a zone of I don't know to I don't know. And then the next time you do this, you will start improving. That I don't know will move to I know. Okay, so let's go on. Next. Tell me.
58 patients were enrolled and randomly assigned, 31 to SABR and 27 to surgery. Median follow-up was 40.2 months.
Okay, just stop. Let's go with the first one. First line. Okay, let's go with the first line.
Yes, sir.
Any comments you want to make on this?
Sir, 58 is a very less number, sir.
58 in how many trials?
2 trials is very less.
This is the key. You kick them on the ass, because 58 in 2 randomized controlled trials, 2 multinational, multi-center randomized controlled trials, which means 26 or whatever it is, 25 and 4, 29 in each trial. Can you imagine? Can you actually make a clinical decision on changing practice in the world on the basis of 29 patients? And not even 29 patients, it is 29 times 2, so 14 patients. Can you actually change the world? In Lancet Oncology, and you have the audacity to stand up in front of the world and say SABR is as good as or better than surgery in stage 1 in lung cancer. 14 patients. Can you do that?
It is very less.
I will kick the ass of this guy. This is so terrible. This is so terrible. 58 in, so even worse is look at 27 to surgery. So
Yes,
which means there were 14 patients in each group, in each study, okay, approximately.
Yes, sir.
And out of that, if you randomize it, it's 7 and 7. Oh God, how the hell can you make analysis on the
Yes, sir.
14 patients? That is so bad.
Yes, sir.
Isn't it? So this is the trick here. This is all wrong. Everything wrong. Okay? All right.
Yes, sir.
Carry on.
Sir, then they say median follow-up was 40.2.
1 minute, Amol. When you make your analysis, I want you to mention, this is a strong point, okay? That 58 patients were spread across 2 RCTs, which were multinational, multi-center. I mean, this is highly underreported. So what does that mean? What is the word that you will use?
Sample size is too low.
It's not calculated. Forget too low, it's not calculated. Because how the hell can you have power of a study?
Yes, sir.
I mean, and how the hell can you have a distribution coefficient which gives you an
Yeah.
answer of 58, which means you are looking for a difference of about 20%, not
sir.
95% confidence interval.
Yes, sir.
If you're using 95% confidence interval, then you got to have a very large sample size. But if
Yes,
you
sir.
use that confidence interval to 30%, you're willing
Yes.
to accept a 30% confidence interval and you're willing to accept a power calculation of 30%, your sample size goes to 27 or 29. So
Yes, sir.
this study is completely wrong. The power, there is no sample size calculation here. That is the language I want you to get out to me, okay? That the
Yes, sir.
power calculation, the sample size calculation cannot be accurate. Either they have accepted a very low confidence interval or a very low power of the study to be able to demonstrate a difference between the two groups.
Yes,
Because
sir.
you're going to accept 95% confidence intervals, or you're going to accept more than 80% power of a study, the sample size would have been at least 300 to 400 or 500. This is the language you have to get across, okay? All right.
Yes.
Next. I'm sorry, I'm starting a little. I'm excited by this paper because it is so rubbish. Okay.
Yeah.
But don't say it in the exam, it's rubbish. You just criticize the valid points that you can see. Okay. All right. Next.
Median follow-up was 40.2 months. The range is between 23 to 47.3 months, sir.
So,
So,
what do you want to say about that?
Sir, the first of all to say the survival, the overall survival according to Kaplan-Meier, it would have been at least 5 years follow-up in this paper, but they have done only 40 months, sir. And in that also the patients, some patients are having very low follow-up, and some patients are having. There is a difference between the term for which the patients are followed up, sir.
Absolutely.
23 versus 47.
This is quite different. 35 versus 40. I'm sure if you do a parametric analysis, you will find a statistical difference. This is, it's a small sample size, and there's so
Yes, sir.
difference, 5 months almost difference. And more importantly, look at this 18.9 and
Yes, sir.
47. That does not ring true. The interquartile range, which means some patients were followed up, because interquartile range is 25%, isn't it? So whenever
Yes.
they say IQR, quartile means 25%. So when you're using IQR, you're reporting 25% to 75%. Okay.
Yes, sir.
But
Yes, sir.
you've also got to understand that some patients are below the 25% IQR.
Yes, sir.
If this was 18.9, then at least 25% of the patients have been followed up less than 18 months.
Yes, sir.
Yeah. And again, here, at least 25% of patients have been followed up less than 23 months. Okay.
Yes, sir.
Good. Go ahead. Next line. Let's look at the next line.
6 patients in surgery group died compared with the 1 patient in SABR group.
Okay. Now.
Yes, sir.
On this.
Sir, the cause of death, I don't know whether it is required to be mentioned in the abstract, but they have not mentioned it here.
Before the cause of death, what do you want to say in this? This is very, very important line.
Yes.
What is a risk, a mortality of a lobectomy?
Sir, it is less than 1%, sir, less than 1%.
Yeah, 1%, 1 to 2%.
Yes,
What
sir.
is 1 to 2% of 27?
It's not even 1, sir.
Yeah, it's about 0.5 or 0.75.
Yes,
What
sir.
is 6 of 27? 6 out of 27 is how much percentage?
It's almost 25%, sir. 25%.
Okay, so if you were a surgeon and I was going to refer you a patient for a lobectomy, and you declared to the world that your mortality was 25% in a stage 1A operable lung cancer. Okay, stage 1A operable lung cancer. Would you actually keep your medical registration?
No, sir.
The Western world?
No, sir.
What would happen to you?
Sir, it is actually these results are not.
What would happen to the surgeon? Tell me what would happen to the surgeon.
Thrown out of
Audit.
medical practice.
Either his license would be rusticated, or number two, more importantly, he might be sent for retraining. Yeah, these are the two
Yes,
things
sir.
that happens when a medical council, comes down upon you. One is either they stop your license, or they say you need to retrain for 1 year, 2 years before you can start doing this. So, what do you think about this?
Sir, they have overestimated the mortality, sir.
No, it is incorrect.
Maybe.
Correct. The surgeons were not right. I don't know what the hell they were doing with 6 patients dying in an operable stage 1A lung cancer. Huge problem. Huge problem.
Yes.
And even worse is, what the hell is this patient dying for?
Yes.
The whole idea of you doing SABR is because you say the morbidity is less, right?
Yes, sir.
But where you're having 1 patient die out of 27. I mean, what is the mortality of radiotherapy in a fit patient undergoing a procedure for a stage 1A or 2 lung cancer?
It should be 0, sir. Means they should not.
No patient should die, man. No patient should die, and then 1 patient has died. Okay.
Yes, sir.
So now, what should the next line have been immediately in this?
Sir, I think they are not talking about the operative mortality or the mortality during radiotherapy, but they're talking about the 3-year mortality. I mean, at the end of 3 years.
Maybe you are right. I don't know. Maybe you're right, because we are still just at the abstract.
Yes, sir.
You may be absolutely right. We are still at the abstract. So if I read this in an abstract, then they have to clarify to me that 6 patients in the follow-up died in the surgery group.
Yes, sir.
Okay. I am really concerned. As a reader, if I read this, I am really concerned. What the hell are they doing? So this is not a well-written sentence, because
Yes, sir.
it tells me that 6 patients died from surgery. You
Yes,
understand?
sir. Yes,
This
sir.
is what they said, isn't it? 6 patients in the surgery group died, right?
Yes, sir.
Calculate mortality of a surgery. How do you
30 days.
calculate mortality? What is the period you look for when you're
30 mortality, sir.
30-day mortality? So the moment they
30
make a statement like this in the paper, and they're saying 6 patients in the surgery group died, I am thinking that they're talking about 30-day mortality.
Yes,
You
sir.
have now clarified to me that this was not a 30-day mortality, but the authors have not clarified to me. You
Yes,
understand?
sir.
So there is a real problem with this group. And if the patient died 30 days later, then did you die because of surgery?
No.
No.
Yes.
But they have the audacity to say that 6 patients in the surgery group died. Hence, the overall survival was so and so. You understand? There is a real problem with the way this paper is written. Because
Yes, sir.
if the patient died of cancer or if the patient died of MI, then there is no reason to attribute that death to surgery.
Yes, sir.
So both ways you can argue. Even if you understood that they're talking about a long-term follow-up, this thing, but they are attributing that death to surgery. Just
Yes, sir.
as they're attributing one death to SABR. So that is a problem. The way this is written is not correct. I have a huge problem with the way this is written. Okay,
Yes, sir.
let's go to the next. One more thing. What is missing in this?
The previous sentence, sir.
After this or before this sentence?
Should have said all cause mortality.
All cause mortality. Yeah, we've understood this sentence now. But if you had to write a good paper, what would you write before or after this sentence? What would you tell?
Statistic, whether it is significant or not.
No, morbidity, yaar.
Morbidity. Yes.
Because one of their statements at the end will be that SABR has less morbidity than surgery.
Yes, sir.
Assuming that that's what they say. I have not yet gone down, but I'm assuming. So they have not mentioned morbidity, at least not till now.
Yes, sir.
So that is a problem. When I talk about mortality, I immediately want to hear morbidity. In
Yes,
fact,
sir.
in a paper, always morbidity is written before mortality is written. You agree or no? Because that is what happens immediately post-operatively.
Yes, sir.
That is missing. So I have a problem with that they have not mentioned morbidity. Let's go down to the next line. Okay.
Yes,
They have also not mentioned the success also, whether after all patients were cured or not.
Yeah, I think they're going to talk about recurrence in a minute. I saw the word recurrence a bit
No, but
late.
recurrence is a different thing. I mean, in the first stage itself, when they gave treatment, I mean, surgery was done or they gave radiotherapy.
Yeah,
After radiotherapy, what the lesion disappeared or not in all the patients.
yeah, sure. They should have mentioned that. I agree with you. Okay, let's go to this line, the next line. Okay. What do you think about
estimated overall survival at three years was 95%, with confidence interval of 95% confidence interval of 85 to 100 in stereotactic radiotherapy group, compared with 79% with confidence interval of 64 to 97 in surgery group.
okay,
Hazard ratio.
stop.
Yes, sir.
So what are they trying to tell you here?
Sir, they are trying to tell that overall survival is better in SABR compared to the surgery.
And do you believe this? Would you ever believe this?
No, sir, because our previous studies on lung cancer, who have studied stage 1 cancer, they have showed that the survival is much more than 79%, which is mentioned here.
Absolutely correct. This is not only that, but who spoke about the death? They are talking about long-term deaths. Who was that? I can't see you, so I don't know who spoke.
Sir, me, Anish.
Anish, they have the audacity to actually say that surgery caused the death of the patient. The moment they make this statement, they are actually telling you that patients who received surgery die sooner as compared to patients who receive radiotherapy. You understand that? So
Yes,
this
sir.
is a real, this is a very biased study. Okay,
It's a molded statement to show what they want to show.
seriously more. So, but it's good for you, because if you get a paper like this, by God, you can write 10 pages on this. And I have not even gone down to the study as yet. I'm still on the findings. And I've already spent 1 hour and 30 minutes talking about the problems with the paper. Did you understand what you missed out? All
Yes,
of
sir.
you guys missed out on so much of stuff. And if I was an examiner and you bought all this out, what do you think I would have given you? If you had to grade yourself out of 9 and you told everything that I've said in this discussion, how would you have graded yourself? 8 or 9? You agree?
Almost
Yes, sir.
full mark. Yes.
You would have got 8 or 9, because by God, you're talking the language of a researcher.
Yes, sir.
However, if you read just your paper, what you have done the analysis, and you told that to the examiner, what do you think you would have got? 5?
1 or
5, 6, maybe? So the
not even.
always about 8 and 9. How to go to 8 and 9. So it's all about language. Okay.
Yes, sir.
Okay. So let's go on a bit further. Is everybody understanding what we are saying, or is it getting to be too much? I keep asking this question because whatever we do today, it's got to benefit the audience. If the audience is not with us, then there's no point in doing this session. So that's why I keep asking for feedback. Okay. All
Yes,
right.
sir.
Yeah. Okay. So read the next line now. I'm not going to go into the statistics just as yet. We can criticize the statistics a bit more.
Yes, sir.
What do you think about this?
Sir, it is significant, sir. P value is significant. It is less than 0.05.
Do you think they've used good statistical methodology?
They have used log rank for this.
No, but do you think the method,
Not,
statistical
it's not,
that they have
it's
used,
not
This p-value in a sample size of 58.
It is not strongly suggestive of
How the hell with 31 SABR and 27 surgery, you're getting a p-value of 0.037? How the hell are you getting? This statistics has been massaged. You know the concept of massaging statistics, isn't it?
Yes, sir.
Yeah, massaging means you use the test which gives you the best results. So you try many tests on your SPSS, and then you work with various tests and try to fit the test to your outcome rather than the outcome to your test.
Yes, sir.
Value is a real problem. Yeah.
Yes, sir. Yes.
And again, confidence.
Sir, 79 was 95, sir. So it may be true also, sir. 79 was 95, no, sir. So that according to that statement, the p-value may be.
But with a sample size of 27, can you actually get a p-value of 0.3?
Okay.
Really?
Sample size is very okay, sir.
Can you get such a highly sensitive result?
No, sir. No, sir. Okay, sir.
Smaller the size, I could have understood, a
200 patients.
Difference I could have understood, but this is too significant for me. At least that's my take on it. There is no right or wrong in this. Okay, there's no right or wrong. But the feeling I got when I read these numbers was that they have actually massaged. I feel. Okay.
Okay, sir.
Next line. Again, there is no right or wrong in this. Okay, it's all interpretation.
Yes,
Okay.
sir. Recurrence-free survival at 3 years was 86% in the SABR group and 80% in the surgery group. P-value is not significant, sir.
Okay, so now this one again. Okay, come back to this one.
Recurrence-free survival at 3 years was 80%.
Survival. Surgery with systematic mediastinal lymph node versus radiotherapy, localized radiotherapy to one area. And
Yes,
they are telling you that the recurrence with localized radiotherapy to one area with nothing done to the lymph nodes has a less recurrence than surgery, which is so invasive. Do you think that's a valid statement?
No, sir, because in SABR they have not addressed any lymph nodes. Nothing they have done for.
How do you know recurrence? Tell me, how do you know that a patient has had recurrence?
Sir, if patient comes up with the lymph node metastasis or distance metastasis or primary site is showing some other growth.
Okay. So now my question to you again is, if you give radiotherapy to lung cancer, okay? You give radiotherapy to lung cancer, what happens on a CT scan?
Sir, there will be a fibrosis in that area.
So on a CT scan, does it become completely normal lung?
No, sir. The lesion will still appear, but it may not appear like a CA, but it appears like a lesion which has undergone.
Actually, it appears like a CA because it's fibrotic and coiled, and it has got spikes. You actually see a lot of post-radiotherapy chest X-rays or CT scans. What does fibrosis do? It just shrinks down, isn't it? And it pulls in the tissue around it. And
yes,
so, one of the problems with radiotherapy is that in the follow-up of patient on a CT scan, it's very difficult to know if the patient has histological recurrence in that scar or not.
Yes, sir.
You understand that?
Yes, sir.
Here they are saying the recurrence-free survival with radiotherapy was longer than surgery. What happens with surgery? Everything goes away.
Yes, sir.
Yeah, the job is gone. There is no scar left.
Yes, sir.
So when you see a recurrence in a surgical patient, it means it is M1.
Yes, sir.
You understand? It's M1.
Yes, sir.
In a radiotherapy patient, if you see recurrence on the local side, it is a failure of the treatment. It is still T1. It's not M1.
Yes, sir.
So even if you say you have 86% success with a treatment.
Yes, sir.
What is local recurrence you are looking at, not at M1. You understand? So what they are doing is they are comparing apples and oranges.
Yes, sir.
This fact.
Yes, sir.
So they are actually comparing apples and oranges and then making a conclusion on the basis of this. Because in surgery, the lobe is gone. How do you know where is recurrence? If recurrence surgery happens, it means it is M1. Something else grew somewhere else.
Yes, sir.
So here, this is completely wrong. This statement is a real problem because they have the audacity to say that a scar recurrence is equal to a recurrence in the left lower lobe. Because you also
not
about the mediastinal lymph nodes.
Yes, sir.
You know, they did not. They don't know what the hell. There could have been micrometastases in those lymph nodes which grew. And now they are calling it recurrence. I mean, that is so wrong. So wrong. Okay? Is it making sense, guys? Hello?
Yes, sir. They are means here they are not comparing the identical
They're
situations.
not. The CT is not the same. One CT has a right upper lobe left behind, and one CT has no right upper lobe.
Yes, sir. And technically also, it is not possible.
It's not possible to compare recurrence between SBRT and surgery. Technically, it is not possible to compare. Yeah? Okay, good. Are you understanding now how you rip into a paper?
Yes, sir.
Yeah. Yes, sir. Okay. All right. Next line. Let's just do this abstract today only. I don't mind, but I want you to understand. The whole paper can be read in detail, but the abstract gives you a lot of clues to what's happening. Okay.
Yes.
Read me the next line.
In the surgery group, one patient had regional nodal recurrence and 2 had distant metastasis. In SABR group, one patient had local recurrence, 4 had regional nodal recurrence, and 1 had distant metastasis.
Okay, stop. Now tell me what is the problem with this sentence.
Sir, in surgery, we have taken out the lobe, sir. How can there be a local recurrence?
No. Local nodal recurrence they're talking about, which I understand. I accept that there could be a nodal recurrence.
Yes,
the
sir.
second line is the problem. Because when there is, this is not correct. It cannot be nodal recurrence. It is actually a metastatic disease. So they have divided this into nodal recurrence and distant metastasis. So that is a problem, but we understand. But what is even worse here? The second part of the line, what is the problem?
So the 4 regional nodal recurrence in SABR group could actually be the residual disease.
Absolutely right. These are not recurrences. The patient was metastatic in the first place.
Yes, sir.
You have not sampled the lymph nodes in the midline to actually give a correct pathological diagnosis that this is truly a stage 1 tumor. It could have been a stage 4 tumor to begin with.
Yes, sir.
So you this patient.
Crime in.
Absolutely right. So you understand that. So they actually have the audacity to tell you that there were loco-regional nodal recurrence. They're using the word recurrence. For God's sake, how can that be recurrence? That is primary disease. That is not recurrence.
Yes, sir.
You did not treat the guy. You did not stage the guy adequately. It's not recurrence. It is metastatic disease. The patient was metastatic from the word go.
Yes, sir.
Yeah. Again, I'm not going into details of thoracic surgery here. Guys, please understand. I'm just using thoracic surgery to analyze how people massage data and how they present it to you in a very respectable way. And if you are not smart, then you will not pick up any of these.
Yes, sir.
And when you've got somebody like me in the audience, I told you this before as well, that if I'm sitting in the audience and I see this slide coming up, what do you think I'm going to do? I will tear him apart. Limb to limb, I will tear him apart. But the problem is 98% of the audience does not know how to read data, which all 6 of you probably didn't realize it till I have pointed out to you. So the moment this guy finishes his paper, I will stand up, run to the mic, and I will tear him apart limb to limb, point wise. 1, 2, 3, 4, 5, 6. If the chairman allows me 6 questions, Or if not, I will just ask him 2 questions, but his paper will be shredded to pieces. You understand that? That's how you should become. I'm not saying in a conference you please criticize somebody, but your mind must start to think like that. Yeah.
Yes.
Okay. Let's go to the next line.
Sir, one doubt. Sir.
Yeah. Please.
Sir,
Who is that? So, Vinita, sorry, there's only one lady today.
Sir, if the initial, because they did a PET CT for all patients, so if the initial CT had no enlarged lymph nodes and the follow-up showed an enlarged lymph nodes, then can it be taken as the recurrence?
No, unless and until a PET CT positivity or negativity is not an indication of presence or absence of metastases. The only way you can tell whether the patient has cancer cells is by histology. And surgery is the only way you would have gone and done a histological sampling of the lymph nodes, which they have mentioned. In an SBR, in a stage 1A cancer, even the guidelines say that you don't need to do an EBUS or an EUS for a stage 1A cancer.
Yes.
Okay. So there is actually no histology. A PET negative CT does not mean that the patient does not have micrometastases.
Okay.
Because the only time PET will come positive is when it is greater than 1 centimeter.
Yes, sir.
But if it is a 0.4 millimeter or a 0.1 millimeter metastases in the lymph nodes, the only time you can say it is positive is when you surgically take it out and do a histological analysis. So I will not agree with that unless they've done an EBUS. And even in an EBUS, if they have done a correct EBUS, as in more than 4 to 5 passes through the lymph node. But the problem is ESTS guidelines say a peripheral tumor with no evidence, with a PET negative mediastinum can be operated upon.
Yes, sir.
But when you operate, you still have to take lymph nodes out.
Yes.
Whereas the
Yes.
SBRT guys are doing nothing. They are
Yes, sir.
not taking out any lymph nodes. Okay? All right.
Yes, sir.
Carry on.
But the guidelines apply only to surgery, sir, because we are taking out the nodes during the surgery.
Yeah. It is a surgical guideline.
Yes, sir. That the same guidelines cannot be followed up for this SABR, sir, because we are not.
The guideline is management of locally of operable stage 1A lung cancer. The guideline says no SBRT for stage 1A lung cancer.
Yes,
Okay. So if they are genuine followers of guidelines, then they should not be doing SBRT.
Yes, sir.
The paper should not have come out at all.
The paper should not have.
No paper.
Forget the paper coming out. This study should not have been allowed because 50% of patients actually received a wrong treatment.
Yes,
Yeah?
sir.
Okay.
Yes, sir.
Carry on. Let's finish this.
Three. That is 10% of the patient in SABR group had.
Where are we are here, isn't it? We did this. Okay. So let's look at the next line. Okay. So 3 patients. Go on.
3 patients, that is 10% of the patient in the SABR group, had grade 3 treatment related adverse events. 10% chest wall pain, means that is 3 patients, that is 10% chest wall pain, 2 patients, that is 6% dyspnea or cough, and 1 patient, that is 3% fatigue and rib fracture.
What do you think about this line?
They are again comparing some outcomes which is not at all possible in SABR group.
Which is the one you have a problem with this? Which is the outcome which is a problematic outcome in this?
None of them.
No, there is one outcome which is a problem, which very quickly my eye caught onto. Which one?
Rib fracture.
Now, one is rib fracture and chest wall pain.
Yes, sir.
In a stage 1A lung cancer, if you've got a rib fracture, then there is a problem. This is a metastatic disease, unless proved otherwise. That's one. And number 2, if you've got chest wall pain, SBRT does not cause chest wall pain. So if you're getting chest wall pain, that means there is some invasion of the chest wall, or there is a metastasis somewhere in the ribs. You understand? Both of these are a problem in this. Chest wall pain and rib fracture. Not sure. This is a metastatic disease.
Yes, sir.
No, if a lung cancer patient comes and tells me, If I've operated and he says I've got chest wall pain, that's different. I can accept that. But if I've not operated, he's had SBRT, why the hell should he get chest wall pain? I'm not clear about it. Okay, next. Next line.
Yes, sir. No patients given SABR had grade 4 events or treatment related deaths, sir.
Okay. No big deal about it. You know, they're making a big deal that look, in our group of patients with operable stage 1A lung cancer, operable, okay, with no comorbidities, yeah, with no comorbidities. Oh, we had no deaths. It's nothing. There's no blowing trumpets about it. You know, whether you do surgery or SBRT, you should not have deaths in these patients. Okay, that's the reality. So they have actually in an abstract which has got only 250 words, they have actually put in a statement to say this.
10 words.
Yeah, 10 words. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 words. And they do not explain to you what is stars and rosal, but they managed to put this line in there. You know, and very quickly they've called it as grade 4 events. Very quickly, grade 4 events. Wow. So anyway, this is a biased paper. Okay, this is what it tells you, that this is a biased paper. Okay, next.
Yes,
next line.
In the surgery group, one patient, that is 4% patient died of surgical complication, and 12, that is 44% patient had grade 3 to 4 treatment related adverse events. Grade 3 events occurring in more than one patient in surgery group.
Okay. Okay. Stop. 1 minute. Anish, come back in. You were defending them, isn't it?
No.
Telling me that they are talking about long-term deaths and not post-operative deaths. Yeah, you told me that. Look at what they are just saying. 12 patients had grade 3 to 4 treatment related, and one patient died of surgical complications. Which bloody patient dies of surgical complications in a stage 1A? I'm really worried about this paper. Okay, so don't think don't try to protect them. They are screwing you straight away in this paper. Okay, all right.
Yes.
And keep reading the grade 3 events.
Grade 3 events occurring in more than one patient in surgery group were dyspnea, that is 4 patients, 15%, chest pain occurring in 4 patients, that is 15%, and lung infection in 2 patients, that is 7%.
Okay, now let me come back to this. Okay.
Yes.
If you calculate in a fit patient, okay, who is operable for stage 1A lung cancer, should he get dyspnea?
No, sir. There is no reason why patient should have.
No reason for that. They are just massaging data. Okay, I bet this guy with lung infection, 2 of them got dyspnea. Okay,
yes, sir.
I bet you. And that is what they're using. They're using dyspnea as a separate indicator and lung infection as a separate indicator to show you that actually surgery is a horrible thing for patients. And they're talking about grade 3 events. Yeah.
Yes, sir.
But in their lot, grade 3 is okay. It is the grade 4 that is not okay. Yeah.
Yes, sir.
So surgery, if you get a grade 3 event, that is bad. But in a SABR, if you get grade 3, that's okay. Yeah. Okay. Let's go. Next line.
Interpretation. SABR could be an option for treating operable stage 1 NSCLC because of the small patient sample size and short follow-up. Additional randomized studies comparing SABR with surgery in operable patients are warranted.
What do you think?
Sir, option, I don't think it's an option
No,
for operable.
The question is, when you make an interpretation, you have to make a null hypothesis, isn't it?
Yes, sir.
And then you have to disprove the null hypothesis. Did you realize that the only piece of statistics in all of this is in the death rate?
Yes, sir.
Yeah. And recurrence-free survival, which is all fallacy. None of this has any statistics attached to it. The second half, all the morbidity, has no statistics attached to it. And on the basis of this statistics, they are actually telling you that SABR is an option for treating stage 1 lung cancer.
Yes, sir.
So how do you reach this conclusion? How do you reach, on what basis have you reached this conclusion? Is this conclusion correct? Is it valid?
Sir, but in the main paper, if they explain it, so is it okay to say that this interpretation
We'll
which
find out in the main. If we eventually do the paper, we'll look at the main paper as well. But at this moment, what data we've got in front of us, say I give you an abstract to analyze, this is how you would do it. I don't know what's in the main paper. So if we actually read through the main paper, and if they actually showed us statistics showing that this is better than that, I would accept the conclusion. That's not a problem. But from what they have put in the abstract, I would actually reject this paper for oral presentation. If I was shortlisting, if I was shortlisting for the European meeting and this paper came to me, I would actually reject this paper.
Yes, sir, because
I would accept it for audience bashing. You know? So that I could discuss it and I could bash the guy up.
yes, sir, it would be very interesting to have this paper in discussion, sir.
Yeah, so that's why I put this paper up, because it's a very controversial paper and there's a lot of learning for you guys from this paper. Again, don't get me wrong, it could be that SABR is the treatment option. It could be that surgery is too violent. It is possible. I don't know that. But I wish they had done a good study to tell me that. 56
Yes,
patients, and they are quickly reporting this, a multi-center, multinational study, with a sample size of 56. And then to sound very scientific, they say our patient sample size is small. And even worse is our follow-up is small. This is a typical trick which people do, that they actually make a very dramatic statement as the first line and then balance it out. And the other word is could be, or maybe. This is just a way to instill the doubt in the population. So the word could is used. Whereas no guideline talks about could. Okay, no guideline says that SABR is an option for treating stage 1A lung cancer. Okay, does it make sense?
Yes, sir. Yes, sir.
Okay, let's look at the funding also quickly while we are here.
Funding is by Accure Inc., Netherlands Organization for Health Research and Development, NCI Cancer Center Support, NCI Clinical and Transitional Science Award.
Okay. So again, my issue here is this translational science. Okay. So if they are talking about translational science, there is no mention of any translational science in this. There is no looking at genetics, genomics. They're not spoken about the histopathology of the organism, of the tumor. They have not compared squamous versus adenocarcinoma. We know that SBRT works well in squamous cell, doesn't work as well in adenocarcinoma. So in the there is no mention about the histology of the tumor. And more importantly, when you do a SBRT, when you do a surgery, you have a whole sample to look at. And you can do immunohistochemistry and everything. Whereas I'm pretty certain these guys have not done immunohistochemistry and all that.
Sir, in one study, they have not even taken tissue, sir.
Okay, so they have not even taken tissue. So that's even worse. You understand that? So this is how you criticize. This is how you... I'm not going to go longer today because I wanted to actually focus on what to say. Okay. Now, if you read the whole paper, you will be able to pick up all these things. Okay. So we'll stop here for 1 minute. Let me just stop sharing. I want your feedback with me. So just on the basis of the abstract and the title, I did a lecture for 2 hours, or we did a discussion for 2 hours. Do you understand that?
Yes,
so
sir.
You should quickly practice this again and again and again, so that, so a lot of people say, oh, in 1 hour, how can I pick up all these things? The key thing is look at the abstract, man. The abstract will give you a lot of material. You immediately write down these points, okay? And then when you've written all these long list of points, you read the abstract very carefully. And then quickly write down 10, 20, 30, 40 points. And then when you read the paper, rest of the paper, you then add to these points, okay? Or you refute some of the points that you've made. So when you're reading a paper, read the title carefully, read the journal carefully, read the authors carefully, read the aims of the thing carefully. The abstract is very important. Use the abstract to get you at least 3 to 4 pages of data. And then look at the paper. So within 10 minutes, you should be able to get all these points in. Yeah? And then you have another 30, 40 minutes to look at the paper. And then when you look at the paper, you look at more points and try to refute some of the points you've made before. So like he said, it could be that the 6 deaths were because it was in follow-up. At 1 year, it was the death. That you try to find out from the paper. That is this what happened, or is it genuinely that these guys died within 30 days? Okay?
Yes, sir.
Sir, I would like to add one point.
Go ahead.
Sir, this funding part, this study is funded by this Accurate Netherlands. This Accurate is the company which makes cyber knife and radiotherapy machines.
Well done. If you know that, then that's even better. I probably didn't know that, so I couldn't put that point across. But if
I actually Google.
that actually is the company which makes cyber knife, there you are. This is a strong point that this is a industry sponsored study.
Yes.
Very important point. Okay. I didn't know Accuray makes cyber knife, but very good. If you have in a cardiac thing, if you have a Medtronic sponsored study and it says Medtronic valve is better than Sorin or St. Jude's, then you know. There's one line there. This is an industry sponsored study. So when you are going to do cardiac analysis, which is what you will do, because actually what we want to discuss is cardiac surgery, not thoracic surgery. But I just used this paper because it's such a beautiful example of how statistics are manipulated, or how studies are manipulated to give you the data that anybody can give you. Okay?
Yes, sir.
Let me stop.